Hi, my name is Alexis. For my paper, I did elevated expression of NEU1 sialidase in idiopathic pulmonary fibrosis, provokes pulmonary collagen deposition, lymphocytosis, and fibrosis. So first off, what is idiopathic pulmonary fibrosis? The term idiopathic pertains to any disease or condition that arises spontaneously or for which the cause is unknown. Pulmonary is relating to the lungs, and fibrosis is the thickening or scarring of connective tissue. The medical dictionary defines idiopathic pulmonary fibrosis as a common interstitial lung disease, or ILD, of unknown etiology, usually occurring between 50 to 70 years of age. Clinically, it is characterized by an insidious onset of breathlessness with exertion and a non-productive cough, leading to progressive dyspnea, or shortness of breath. Pathological features show scant interstitial inflammation, patchy collagen fibrosis, prominent fibroblast proliferation foci, and microscopic honeycomb change. So, idiopathic pulmonary fibrosis, or IPF, is one subset of interstitial lung disease. This develops due to genetics, hazardous environments, immune system disturbances, complications in systemic and pulmonary diseases, or for seemingly no reason at all, which would be the section that IPF falls under. So studying the causes of IPF helps us to determine all causes of ILD. With this determination, we can more effectively treat, cure, or prevent the condition. In patients with ILD, pulmonary fibrosis is often the main cause of death. It replaces functional lung tissue with scar tissue, causes architectural distortion and functional decline of lungs. After diagnosis, IPF patients typically survive only 2 to 3 years. So, for this experiment, the researchers put previous data to use. They knew from a previous study that neuraminidase 1, or NEU1, is an enzyme that removes terminal sialic acid from glycoproteins. Previous studies had shown a correlation between increased NEU1 expression in epithelial and endothelial cells, along with fibroblasts in patients with IPF compared to those with healthy control lungs. NEU1 overexpression in fibroblasts led to increased collagen type 1 and 3, prominent changes in global gene expression, and accelerated degradation of matrix metalloproteinase 14. So, their predictions and methods. They predicted that NEU1 would be heavily expressed in those with IPF. It would be the most abundant of the 4 NEUs, and increased activity of NEU1 in pulmonary. There would be increased activity of NEU1 in pulmonary fibroblasts. NEU1 mRNA would be elevated in pulmonary fibroblast cultures of IPF patients compared to controls. To do this, they used lung sectioning, reverse transcriptase quantitative PCR assays, quantitative immunoblotting for NEU1, RT-Q PCR assays for NEU1 mRNA steady-state levels, where they got their lung tissues. So for those with IPF, lung explant or video-assisted thoracoscopic biopsy tissue samples were taken from patients meeting the established IPF criteria. Samples of normal lung tissue were taken from lungs that had been intended to be used for transplant. In a 5 micrometer section of lung tissue were prepared and stained with polyclonal antibody, alkaline phosphatase, labeled GO anti-rabbit antibody, and chromogen, and this gave the NEU1 positive structures of blue appearance. So, NEU1 expression increases in patients with IPF. Expression was revealed in both healthy and in those with IPF. However, it was highly expressed in those with IPF. As you can see from the top row here, this is a 10-time amplified sample of a patient's lung with healthy lungs. And this is a 10-fold sample of those with IPF. And it's harder to see in the 10-fold that the expression increased. However, when you go to the second row, you can see the bronchial epithelium stained was particularly dense on the brush border of those with IPF as compared with those of healthy lungs. And then the last row is showing endothelial cells that also showed NAU1 positive. G here is a healthy control, and then H and I are those with IPF. And again, you can see it's stained darker along the borders. So, to analyze this, figure 2A is a parenchymal lung tissue sample, and it's less stained. However, in areas where fibroblasts are and fibrosis is occurring, it shows to be NAU1 positive. For figure 2B, reverse transcriptase quantitative PCR assays showed NAU1 mRNA in lung fibroblasts is the most abundant NAU. So you can see how much higher that is compared to all the other NAUs. Figure 2C shows quantitative immunoblotting for NAU1 of 7 controls and 8 IPF patients, and it showed NAU1 was significantly increased in IPF lung fibroblast cultures. So wells 1, 2, 3, and 4, along with 9, 10, 11 are control, and 5, 6, 7, 8, and 12, 13, 14, 15 are those of patients with IPF, and as you can see, these are significantly darker than those of the control. Then for figure 2D, RT-Q PCR assays for NAU1 mRNA of 9 control and 10 IPF patients showed NAU1 and mRNA was elevated in IPF patients. And you can see the difference here. So the conclusions they drew. Quantitative analysis of NAU1 expression in IPF patients compared with healthy patients was inhibited by significant differences in tissue cellular, biochemical, and structural makeup of the lungs. However, the researchers could conclude that NAU1 expression appeared higher in pulmonary cells of patients with IPF based off staining intensity of NAU1 positive areas of the tissue in the Western blotting and RT-Q PCR observations in primary fibroblast cultures. So they weren't able to get any quantitative data, but the qualitative data matched up to previous findings. Along with a previous study, the researchers found a strong correlation that NAU1 overexpression may contribute to IPF pathogenesis by limiting extracellular sialidase activity. And there's my sources. Thank you.
What are the effects of lung scarring? Why would the prevalence of interstitial lung disease increase with age?